To the webinar today. We are going to be hearing the final results of. Thank you, Shane. Good morning, everyone, and welcome to the webinar today. We are going to be hearing the final results of the evaluation of the Maryland all-payer model. My name is Catherine Jaricchio, and I work at the CMS Innovation Center on the evaluation of this model. I am joined today by my colleague at the Innovation Center, Kate Sapra, Deputy Director of the Division of All-Payer Models, who will be talking about Maryland's performance related to the terms of the agreement between the state and CMS. Kate will also be speaking later in this webinar about the new total cost of care model in Maryland, which started in 2019. I am also joined today by representatives of RTI International, who conducted the independent evaluation of the Maryland all-payer model. The goal of the independent evaluation was to determine the effectiveness of the model and provide the Innovation Center with the data necessary to inform decisions about the model. Today, you will be hearing from Leslie Greenwald, who will share what we learned from site visits, focus groups, and hospital surveys on what the Maryland hospitals did to respond to the all-payer model. Heather Beal will be leading us through the outcomes, how the changes made by the hospitals translated into changes in costs and utilization that we observed in the claims from Medicare and commercial payers. Lastly, Susan Haber will tie together the implementation findings and outcomes as she discusses lessons learned from the model. Now, I'm going to turn this over to Kate.
Thank you, Catherine, and good morning, everyone. Thank you for joining us. I am absolutely thrilled to have the chance to share Maryland's success under the all-payer model with you today. So as Catherine mentioned, I'm presenting the actuarial cost results. That is, how did the state perform relative to the commitments it made to CMS at the beginning of the model in 2014? The state committed to $330 million in Medicare hospital savings over 5 years. And as you can see, the state vastly exceeded that goal, achieving $1.4 billion in hospital savings over the 5 years of the model. Some of those savings were offset by increases in spending outside hospital walls, but the total cost of care savings were still almost $900 million in 5 years. The all-payer hospital revenue growth was below 3.58%, the state's historical gross state product. In addition to impressive cost savings, the quality of care for patients in Maryland hospitals improved. Hospitals reduced complications by 51% across all payers, and the Medicare readmissions rate went from above to below national. In short, Maryland outperformed on their cost and quality commitments to CMS during the all-payer model. Now I'll turn it over to Leslie to talk about how hospitals changed their practices in response to the incentives under the model.
Good morning. This is Leslie Greenwald from RTI. In our evaluation, we were interested not only in the impacts of the Maryland all-payer model, but also how they were achieved. We asked, what strategies did hospitals pursue to operate successfully under this model? We'll review our findings that address this question in the next section of the presentation. The evaluation team tracked strategies designed and implemented by hospital leadership over the course of the evaluation through site visit interviews and clinical staff focus groups. We found that these strategies developed over time as, one, hospitals became more familiar with the all-payer GBR model implementation, and two, as hospitals learned the specific challenges their organizations faced to successful operation. In the last year of the evaluation, in 2018, we documented the strategies employed by Maryland hospitals through a survey of hospital chief financial officers. We received responses from 100% of hospitals. As you can see, strategies fell into three basic categories: staffing, clinical care, and health data and analysis. We did observe a lot of commonality, with most hospitals hiring and deploying care coordinators, discharge planners, and social workers to support clinicians and patients in better managing their care. Patient care plans and patient care transition programs were also nearly universal strategies. Almost all hospitals use the Maryland CRISP data tools and customized data analytics to improve efficiencies in care. Other strategies, particularly those related to the clinical delivery models, varied a bit more across Maryland hospitals, dependent mostly on the specific clinical challenges those organizations faced. As we just summarized, hospital leadership developed and implemented a range of strategies to operate under the all-payer model. Still, during our site visits and focus groups, we also received feedback on a range of factors that hospitals really couldn't control, but which either facilitated or inhibited hospital progress in shifting towards value-based care. So first, the inhibitors. We call them headwinds. Almost all hospitals we spoke with found patient compliance a major challenge. While hospitals generally found success through investing resources in care managers and discharge planners and care plans, their patients' understanding and ultimate compliance with these new approaches was difficult to achieve and time-consuming. We often heard from nursing staff that getting patients to change some of their patterns of behavior, so for example, eating differently when newly diagnosed with diabetes or making follow-up appointments rather than rely on the ER for non-acute care, were major frustrations. We also heard that in some communities, often in rural or economically challenged areas, primary care practices, housing, and other non-medical resources that support improved outcomes weren't always available to support the goals of the hospital's initiatives. For example, an emphasis on primary care in place of ER or hospital admissions was really only feasible to achieve if the community had enough primary care practices in place. We also heard about factors that facilitated progress. We called them tailwinds. These included strong leadership and a clearly articulated vision, often combined with a culture of improvement. When hospitals were able to leverage these positive factors, clinical staff were more engaged, strategies were designed and implemented more successfully. We heard often that leadership mattered. Presence of clear leadership and a collective and communicated vision of what was being asked of hospital staff, clinicians, and other stakeholders supported key facilitators of progress, a culture of improvement and opportunities for real reduction in wasteful practices that allowed scarce financial resources to be diverted elsewhere more productively. We also observed factors that, and to continue our weather metaphor, could blow both ways among hospitals. Physician engagement and clinical accountability, when present, contributed enormously towards progress, but when absent, these were major challenges. Fixed revenues, when combined with successful management of the new model, could add flexibility to direct financial resources according to desired outcomes. But when unsuccessfully managed, we observed frustration and a sense that there simply wasn't enough money to go around. As part of the evaluation, we looked at how well hospitals were able to operate within GBR targets. We found in 2018, the latest available year, that most hospitals were able to stay within their targets. A few characteristics appeared to be associated with meeting GBR targets. Looking at the yellow highlight, small and non-teaching hospitals were less likely to be budget compliant in 2018. Looking at the blue highlight, non-type TPR hospitals, which are also the larger urban and system hospitals, were more likely to be budget compliant. Experience with TPR was only associated with GBR compliance earlier on in this project, or early on in the project. These findings suggest to us that the economies of scale and management resources available to larger organizations was an advantage in compliance with this very complex model. We also looked at operating margins for hospitals over the course of the project. Overall, operating margins increased by 2018, the end of the project. The only year that margins decreased on average was just before the start of the program in 2013. We view this as an important point since the all-payer model does require investment in management and systems that are dependent on positive hospital margins. Our evaluation looked at the initial implementation of the Care Redesign Program, or CRP. We added feedback on CRP as part of our site visits, and we conducted a series of specific CRP physician participant focus groups to our data collection. Generally, we found that CRP participation for hospitals, but mostly for physicians, was slow at first but improved over time as more information and understanding about the program filtered through to physician participants. When physicians learned that CRP participation could qualify them under MACRA, this seemed to make a big difference in terms of participation. For example, one hospital leader told us, "We've been participating in CRP for a year, going on 2, and the docs are getting 25 cents back as a result of the shared savings. I mean, they've got to be incentivized better than that." Again, using the colloquial term we have coined here, the macronization, getting them approved for MACRA, getting them approved for an alternative payer model. If that works, then that's worth it to them. Generally enthusiastic and engaged participation from physicians may be an ongoing challenge to be addressed. As one physician told us, and to quote, "To actually change behavior, you have to have good data that shows us exactly what's going on and what other people are doing. And for physicians to take the time out of their already busy schedule to be doing that kind of analytical stuff, it's hard. It's hard to find time to do much else as a doctor, let alone become a data analyst," end quote. Overall, by 2018, we observed that hospitals were really proud of what they'd accomplished and were positive about the model. We've got some summary points here in the slide, but a few quotes from our actual stakeholders may tell the story better. First, 2 illustrative positive points. From a Maryland clinician, we heard this, quote, "We use CRISP in Maryland, which has been great. When patients come in the ED, they can go right into CRISP, and the clinicians can tell where the patient was. We can see what they got done, what type of care, instead of rerunning all those tests again. It's been wonderful. Being able to have that data, the cost savings are incredible," end quote. Then another quote from another Maryland clinician leader, quote, "Normally the word bureaucracy has a negative connotation, but in this situation, I think that bureaucracy has been instrumental in helping improve quality and providing the resources that we need to solve some of these problems. Because individual physicians can't really see the full picture, they can only see what they're doing, and this provides them a 10,000-foot view of what's happening," end quote. But then, of course, there were ongoing challenges, as you can imagine. Patient compliance is probably the most persistent challenge we heard about in our evaluation. From a Maryland clinician, quote, "Patients, they have no skin in the game. The patient has the ultimate autonomy, so we're being forced into becoming a paternalistic system where we're responsible for people all the time. We can't make people not smoke or return for their follow-up visits. We can incentivize them, but there are diminishing returns and unintended consequences," end quote. And regarding the complexity of the model from a Maryland hospital leader, quote, "The HSCRC is very much the Wizard of Oz for me. It's a lot like someone's behind that curtain. Can someone please just help me understand why this is happening or what happens if that happens," end quote. And now I'll hand over the presentation to my colleague, Heather Beal.
Good morning. Thank you, Leslie. I'm Heather Beal from RTI International, and now we'll be talking about the impacts of the all-payer model on cost utilization and patient experience for Medicare beneficiaries and the commercially insured. So to conduct this analysis, we compared changes in outcomes in Maryland before and after the all-payer model implementation relative to changes in a comparison group observed over the same time period. We call this kind of analysis a difference in differences analysis. So as you might imagine, selecting a comparison group was challenging because Maryland had paid hospitals under a different payment system than the rest of the country under Medicare for decades prior to the all-payer model. So to do so, we used the entire population of hospitals in the United States, and we did a match to Maryland hospitals based on a set of hospital and county characteristics. To select the population for the outcomes, we then identified residents of the comparison hospital market areas. And this resulted in us selecting 48 hospital market areas pulled from 12 states across the United States. The analysis also controlled for differences in individual and area level characteristics. Because of these two things, because we selected a different comparison group and because we're controlling for these characteristics, you'll notice that our findings differ slightly from the findings that Kate presented earlier from the actuarial analysis. We should also note that the commercial analysis is not based on the entire commercial population in Maryland. It's a sample drawn from the market scan database that represents approximately 15% of the commercially insured in Maryland, because it only includes commercial payers who give their data to the market scan database. So moving on to our findings, we found that for Medicare, beneficiaries had slower growth in total expenditures that over the first 4.5 years of the all-payer model, which was the time period that we were able to observe for Medicare, resulted in $975 million in savings relative to the comparison group. These total savings were largely driven by slower growth in total hospital expenditures, not surprisingly, which resulted in $796 million in savings over the first 4.5 years of the model. The additional savings above and beyond just the hospital savings here indicate that the hospital savings were not driven by shifting costs to other parts of the healthcare system that were not under the global budget. The total hospital savings here were driven by slower growth in emergency department expenditures and other outpatient hospital expenditures. And then the additional reduction, above and beyond the hospital savings was due to savings on professional services in hospital settings and also post-acute care services. So moving on to the commercial findings, we did not find total savings for the commercially insured in Maryland after 4 years of the all-payer model implementation, although we did find that commercial plan members had approximately $7 per member per month, or 6%, lower growth in total hospital expenditures relative to the comparison group. The total hospital savings for the commercial plan members was driven by a $6 per member per month lower growth in inpatient facility expenditures, which perhaps reflected a slower growth rate in the commercial payments for admissions in Maryland than in the comparison group. So this slide shows the findings for some key utilization outcomes for the Medicare beneficiaries. So just to quickly orient you to this graph, this shows the change in the percent of each of these outcomes for Maryland relative to their comparison group from before and after the all-payer model implementation. So a negative value here could mean that Maryland had a greater decline in the outcome, or it could mean that Maryland had a slower growth in the outcome. What we found is that Medicare beneficiaries had a 7% greater decline in admissions overall and a 7% greater decline in potentially avoidable admissions. The reduction in admissions in Maryland grew over time over the 4.5 years that we observed, which could reflect the maturation of hospital programs to reduce utilization by avoiding unnecessary hospitalizations. These programs that Leslie alluded to included increased care coordinator, care manager, and social work staffing, took time for hospitals to develop and implement and refine. We found that the admission severity increased more for Maryland Medicare beneficiaries than for the comparison group, which is expected as admission rates decline if the avoided admissions are more likely to be the less severe cases. Both emergency department visits and unplanned readmissions declined in Maryland, but declined at similar rates to the comparison group, so that there was no statistically significant difference. So this slide shows the key utilization outcomes for commercial plan members. Again, the graph, when negative, means that there could be a greater decline or a slower growth for Maryland relative to the comparison group after the all-payer model implementation. For commercially insured, we found that potentially avoidable admissions declined by 6% in Maryland relative to the comparison group, but all-cause admissions and unplanned readmissions declined similarly to the comparison group, so there was no statistically significant difference. We did find here, though, that admission severity decreased relative to the comparison group, which is unexpected with the decline in potentially avoidable admissions because, again, if we're avoiding the less severe cases, we would expect the admission severity to increase relative to the comparison group. The emergency department visit rate declined 3% more among commercial plan members in Maryland comparison group, and we heard from hospitals that they invested heavily in programs to divert unnecessary visits to the emergency department. We think the reason there may have been a significant finding for commercially insured and not Medicare is that it may have been easier to convince commercial plan members to seek care in alternative settings because they are healthier on average than Medicare beneficiaries. So in addition to looking at the overall impact of the all-payer model, we also analyzed whether the all-payer model had differential effects for different types of hospitals in Maryland. So this slide shows the findings comparing hospitals with a high percentage of low-income patients to other hospitals. And I'll quickly orient you to what the graphs here are showing. The bars on the graph show the difference in differences estimate for Maryland hospitals in each group. So here that's hospitals with a high percentage of low-income patients and hospitals with a low or medium percentage of low-income patients relative to their comparison group counterparts. In other words, it's showing the change in Maryland hospitals after the all-payer model implementation relative to the change in their comparison group counterparts over the same time period. The white star in the bar indicates that there was a statistically significant difference between Maryland and the comparison group. And the p-value here indicates that there was a statistically significant difference in the difference in differences estimate between the two groups. In this case, it indicates whether the difference in differences estimates differed between hospitals who had a high percentage of low-income patients and other hospitals. We found that hospitals with a high percentage of low-income patients generally had poorer outcomes during the all-payer model period than other hospitals, particularly for unplanned readmissions and 14-day follow-up visit rates. This finding may be due to the greater complexity and acuity of the patients served by these hospitals. Hospital leaders noted that patient compliance was a challenge in changing patterns of care, which may have been harder for these hospitals because of their high patient acuity or other factors of the population that they serve. We also compared hospitals that were aligned with an accountable care organization, or ACO, to those who were not aligned. Given an accountable care organization's contractual arrangements with both inpatient and outpatient providers, we expected that the ACO participating hospitals would have better alignment with community physicians to improve the follow-up visit rates, as well as greater incentives to improve follow-up care to achieve shared savings. However, contrary to our expectations, we actually found that hospitals aligned with an accountable care organization improved less on patient follow-up visits than non-aligned hospitals under the all-payer model. So this slide shows the results from the HCAP survey looking at patient experience for Medicare beneficiaries before and after the all-payer model implementation. On nearly every measure of patient experience that was examined, Maryland hospitals were rated lower than their comparison hospitals. However, this did not get worse after implementation of the all-payer model. During the site visits, hospitals reported a focus on improving patient experiences. With a few exceptions, Maryland hospitals' patient survey scores improved during the all-payer model implementation period, but we didn't find any evidence that the gap between Maryland and the comparison group hospitals narrowed during the all-payer model period. So now I'll hand it over to my colleague, Susan Haber, to wrap up the lessons learned from the evaluation.
Good morning. This is Susan Haber from RTI, and I want to thank Leslie and Heather for that great overview of our evaluation findings. As you can imagine, this is a 5-year study, so we've really just hit the high points from our evaluation this morning. But if anyone is interested in taking a deeper dive, the final report from our evaluation is posted on the CMS Innovation Center webpage for the all-payer model, Also, the final slide of this presentation includes a link to the final report. So, to summarize, our evaluation showed that Maryland hospitals could operate under a fixed population-based revenue system without evidence of adverse effects on quality or patient outcomes. Most fundamentally, the all-payer model reduced Medicare and commercial insurance spending on hospital services. We also found reductions in total expenditures for Medicare, although not for commercial insurance. The design of the all-payer model directly restricted hospital revenues. This guarantees savings on hospital expenditures as long as global budgets are set properly. Because of this, our findings on hospital expenditure savings are not especially surprising, so utilization may provide more insight into the all-payer model's effects than expenditures. We found the all-payer model reduced hospital admissions for Medicare. Admissions for commercial insurance also declined somewhat more in Maryland than the comparison group, but this difference was not statistically significant. In addition, we found evidence that hospital efforts to reduce inpatient utilization successfully targeted unnecessary admissions. As Heather described, potentially avoidable admissions declined for patients with both Medicare and commercial insurance to a greater extent than in our comparison group. There were concerns when the all-payer model started that restricting hospital revenue could simply shift costs to non-hospital settings. However, particularly for Medicare, we did not find that. And in fact, somewhat surprisingly, we found savings on post-acute care for Medicare. This is certainly one of the areas where people thought that there might be cost shifts. These savings on post-acute care were likely a byproduct of the decrease in admissions because an inpatient stay is required to qualify for post-acute care. Likewise, the reduction in admission likely explains savings on hospital-based professional expenditures that we found. Maryland hospitals showed progress in their engagement and willingness to transform service delivery over the course of the all-payer model, although we did find variation, of course, in how hospitals responded. We don't have information on whether the strategies described by hospital leaders were adopted more widely in Maryland than elsewhere in the country. However, we looked at American Hospital Association survey data and found that Maryland hospitals were more likely to offer certain services that may be related to these strategies than hospitals elsewhere in the country. For example, Maryland hospitals were more likely to offer patient transportation, patient education, mobile health, urgent care, and community outreach services. Despite these positive findings, the all-payer model's exclusive focus on hospital services and the lack of engagement of non-hospital providers was a limitation of the model. We found the largest impacts on outcomes that hospitals can influence directly and limited impacts on outcomes like readmissions and follow-up visits after hospital discharge that require collaboration with community providers. The Care Redesign program was a step toward improving alignment between hospital and non-hospital provider incentives, but we could not assess its impacts because implementation was still in its early stages when the all-payer model ended in 2018. The total cost of care model, which succeeded the all-payer model, was designed to address some of these limitations, and I'm now going to turn things back to Kate Sapra, who will talk about the total cost of care model.
Thank you so much. And now looking forward to the total cost of care model. I'm not going to go into a lot of detail on the structure of the total cost of care model, but you can find more information in our JAMA Viewpoint article, which was published last year. I do want to highlight some of the innovations under the total cost of care model, though. First of all, we want to bring more providers into care transformation in Maryland. We're starting with primary care providers and MDPCP, which launched in 2019, and we're extending MDPCP participation to federally qualified health centers in 2021. We're also including post-acute care providers in the Care Redesign program. Post-acute care providers can participate as care partners starting in 2020, in addition to clinicians who are already participating under the Maryland all-payer model. We've also created a new flexibility to allow nurse practitioners to order home health beginning this month. And we're working with the state to develop an episode-based program to include more specialists in care transformation for 2021. Secondly, we want to align the incentives across providers in the healthcare system. Hospitals currently have total cost of care accountability and downside risk. We want to move our existing programs, including the Maryland Primary Care Program, to a downside risk structure with total cost of care accountability. And any new programs that launched under the model would also need downside risk and total cost of care accountability. Third, there's an increasing emphasis on population health in this model. The statewide integrated health improvement strategy is this framework by which the state is engaging stakeholders to define its quality and population health goals, measures, and targets for the model. This will also be the framework CMMI uses to determine whether the state has improved quality under the model. Diabetes is the first population health goal selected for this statewide strategy, which was in response to an incentive under the model for the state to invest in population health with the promise of a credit towards the annual Medicare savings target for demonstrated improvements in population health. The state will select at least 2 additional population health priority areas, including reducing the burden of opioids among Marylanders. We are also aligning measures in our programs to support the state's population health and quality goals. Now we'd like to open it up for questions and discussion.
Great. Thank you so much, everyone. It's a great presentation, and it allowed us a lot of time to catalog a lot of wonderful questions. So, Kate, since you had most recently done your part, I will start with you. And again, please, my apologies in advance for my pronunciations, but I will do my best. This question, Kate, is the macronization of CRPs, although enjoyed by those physicians who have benefited from them, still seems tenuous. Providers still need to be qualified providers, which is questionable for ECIP in the way described on the QPP website for AAPMs. Can we get a firm commitment that those providers in these programs will have AAPM macro benefit?
Thanks for the question. Care partners are eligible to be qualified practitioners or QPs under MACRA. However, we do still have to follow the determination threshold of QPP. So we as a program team here at CMMI cannot guarantee that all care partners will be QPs. We can only say that they're eligible to be QPs, but ultimately that determination is made through the QPP team.
Excellent. Thank you so much, Kate. Leslie, our next question is for you. Could you tell us more about what you mean by patient compliance as a challenge?
Sure, Shane. So patient compliance, as I said, was a challenge we heard often and fairly much pretty much every year of our site visits and focus groups. There's really 2 sides of this challenge. On the one side, patients who are in the hospital, they're very sick. It's not a time in their life when they're really best able to handle a lot of new information and changed behavior. Some patients are struggling with other issues. They may have social issues such as homelessness or lack of family support. So on the one hand, hospitals and clinicians, and we heard this generally from the nursing staff, are really trying to give good information to patients, to ask them to watch videos about their disease, to give them information about how to do follow-up, to how to potentially change their behavior with regards to self-care to better take care of themselves. And yet patients are while they're in the hospital are at probably the lowest point to be able to really take in that information. So this, I think, is going to be an ongoing challenge.
Great. Thank you so much for that response, Leslie. Much appreciated. Okay, Heather, well, we're going to come to you next. You discussed differences based on hospital characteristics, but were there differences based on people? That is, based on dual eligibility for Medicare and Medicaid, or those with multiple chronic conditions?
Hi, thank you, Shane. Yes, there were differences based on people characteristics too. We did look at that. We found that beneficiaries with multiple chronic conditions and beneficiaries that were dually eligible for Medicare and Medicaid had greater reductions in expenditures and utilization than their subgroup counterparts. And this indicated to us that hospitals may have prioritized the high-cost, high-need patients as they changed their care delivery practices. But we did not find any differences based on the beneficiary's original base of Medicare entitlement, so like disability or race or rural residency.
Excellent. Thank you so much, Heather. Heather, it looks like we have another question for you.
And it looks like, sorry, go ahead.
Go ahead. No, go right ahead.
No, I was just going to say, it looks like there's a number of questions about the 14-day follow-up and whether we included telehealth or other types of touches to patients besides a actual follow-up visit to a physician. And the answer there is no. The measure is specifically, it's a quality measure that has specific things that you can include, and it does only include physician visits. It's a really good point that as providers are going more and more to different types of contacts that aren't billable in the claims data, that we're not seeing those, and I think that's a limitation of that analysis. But if there's not a differential use of those services between Maryland and the comparison group, then the results will be the same, but we don't know that for sure.
Okay, great. Thank you for addressing that, Heather. Another question, Heather, I think is addressed to you. Can you tell us more about the comparison group? What 12 states were used? How many hospitals were included? What type of mix of hospitals? Rural, urban, academic, community? Anything else that you can share?
Yes, so I would first and foremost point you to our final report, which is available online, and we have a link to it on the last slide here that you can see, or you can always Google it as well. It will have nauseating levels of detail about how we selected our comparison group, what hospitals were included, and all of that information if you really want to dig into it. I can tell you the states were Illinois, Kansas, Louisiana, Massachusetts, North Carolina, New Jersey, New York, Oklahoma, Pennsylvania, Texas, Virginia, and West Virginia. The majority came from Illinois. It was a mix of urban and rural. It was really matched on the specific Maryland hospitals. We used an approach called a genetic matching to match the closest based on a set of characteristics to each Maryland hospital. So if the Maryland hospital was urban, then the hospital that it matched to is urban. If it's a rural hospital, it matched to a rural hospital likely. But hospitals could match more than once to Maryland hospitals. So if it was a match to one Maryland hospital, it could also be a match to a Maryland hospital. And so in total, I believe there were 48 comparison hospitals, but Susan can correct me if I'm wrong about that. But again, if you really have more questions about that, I would point you to the report to dig in as much as you want.
Wonderful, thank you. Leslie, we have another question for you. It asks, can you elaborate on any activities hospitals were using to reduce emergency room utilization at the time the patient presented in the ER?
Sure. So there were a lot of strategies, and they varied a bit based on the individual circumstances of some hospitals. But I'll tell you the range of activities. First off, pretty much universally, most hospitals included care managers and social workers in their ERs. Some hospitals that had a lot of ER use would have social workers available in the ER to assist clinicians 24/7. Other hospitals were not quite able to bring that level of resources, and hospitals told us that having care managers and social workers in the ER really helped support clinicians in managing those patients and trying to get them to a better setting. Hospitals were actively trying to make referrals to PCPs. I mean, obviously they can't turn patients necessarily away from an ER, but social workers, when PCPs in the community were available, were helping to set up appointments and make connections and do that kind of referral work, freeing up clinicians. Some hospitals who really felt this was a significant issue for them, hospitals in some cases set up their own primary care clinics, discharge planners, in some cases literally on site, and would try to redirect patients to an alternative setting if it was clinically appropriate. In some cases, hospitals found it was more cost effective to offer those services if necessary at no additional cost, simply to improve throughput through their ER. Then in terms of reducing ER use post-discharge when it wasn't clinically necessary, a lot of hospitals gave patients a 30-day supply of their medications, other supportive devices such as scales or other things to help patients care manage. These were provided to patients at discharge, sometimes with specific appointments at PCPs or discharge planners to provide that level of support and giving patients an alternative to show up in the ER post-discharge if they had a complication. Some hospitals use community health workers to go out and visit patients in the community who were identified as frequent users of ERs that could be directed elsewhere. And that's an important point. I would say almost universally, hospitals use their own EMRs and the CRISP system to be very acutely aware of patients who were presenting at the ER. Sometimes the term, and it's not a pleasant term, but the term frequent flyer was used. Hospitals were very, very, very aware of patients who were utilizing the ER in a way that wasn't most effective either for their patient's own care or for the system as a whole. And these patients, after having been identified, were often the focus of social workers and case managers to try to get them to a more effective method of care. Shane, if you don't mind, there was a quick question that came on the other side that I'll answer. There was a question on the margin chart. Did those margins reflect hospital-only data, excluding other entities within a health system? The answer is yes. It's hospital-only data, and we received that data from the HSCRC.
Great, thank you so much. Kate, looks like we have a question for you. The question is, I agree with the focus on opiate treatment. What is the plan to establish visits, billing, and data that are trackable? This has been difficult for other primary care programs. What is the plan to put this into practice in a manner that will produce data that we can track?
Thank you, Shane. I'll be honest, I'm not entirely following the question, and I think it's a bit beyond the scope of the webinar today, which is focused really on the evaluation results of the all-payer model. So I'm not going to answer this directly given that it's out of scope and not entirely clear to me what the parameters of the question are.
Okay, well, thank you very much for clarifying that. James, I think that was your question. If you want to try to clarify or maybe focus that question a little bit more, I'd be happy to keep an eye on the chat for that. Also, I just want everyone to know, if you did want a PDF copy of today's presentation, I have just opened a handout download window on your screen. If you click on the MDAPM evaluation webinar presentation name, the download file button will become available for you. Looks like, Heather, we have another question for you. Do you have any findings about Medicaid patients under GBR?
So yes, I will say with a lot of caveats. The availability of the Medicaid data during the period of the evaluation was in flux. Like, we did not have available valid data for the comparison group, so we only have data for Maryland, and we did not have data for 2013 for Maryland, so we compared changes from 2011 and 2012 to changes from 2014 to 2017 for Medicaid, just for Maryland only, and we did find that inpatient admissions and ED visits trended downwards from the baseline period to the post period. And then for expenditures, we were only able to look until 2016, and the total expenditures remained flat for Medicaid. So because there's no comparison group, and because the quality of the Medicaid data is a little, we examine the quality, but we're not entirely confident that it's of the highest quality yet. We don't want to put too much stock in those findings.
Great, thank you so much, Heather. Leslie, looks like we can go back to you for a question. The question is, on the margin chart, did those margins reflect hospital-only data, excluding other entities with a health system?
Yeah, and I think I answered that, but the answer is yes. It's just hospitals, and the data come from HSCRC. And we did look at that because a concern, obviously, early on is that the all-payer GBR model would potentially make financial statuses of hospitals worse. That's not our finding, though we will say that within the averages that we present, there's quite a bit of variation. So even though on average we found that there was not a net and persistent decrease in hospital margins, we do acknowledge that the experience of individual hospitals could be quite different.
Okay, great. Thank you, Leslie, for going over that again. I appreciate it. Looks like we currently only have one other question in the queue. And Susan, it looks like this question is for you. Question is, what proportion of the cost savings to CMS is the result of volume reductions as compared to price control through the rate setting process unique in Maryland?
Thanks, Colin. So this is something that we didn't address explicitly. I guess what I would say, though, is that, so we looked at savings and we looked at utilization separately. We didn't try to parse out exactly what percentage, how savings were derived from price versus volume, which is certainly something, we didn't try to tie that together. What I would say, though, is that our savings estimates, at least from the evaluation, those are based on a comparison of the change in expenditures in Maryland before and after the all-payer model with the change in other states. And so the rate setting process existed prior to the all-payer model. So that rate setting process per se doesn't play, doesn't necessarily play into those savings estimates. I think that more, I guess the way I think about this more is not the rate setting process, but really the global budgets themselves and that constraint, and that allowed the hospitals, that the hospitals played with their charges for services to make sure that they stayed within their budgets, and we saw quite a bit of that. So it's a little bit, it's a little bit tough to disentangle what the meaning of the expenditure changes is. For example, we showed changes in inpatient admissions. We showed reductions in inpatient admissions in Maryland that were greater than they were elsewhere in the country. But actually, when we looked at spending on inpatient services alone, we didn't find a difference in the change in spending on inpatient services because hospitals actually were increasing their charges in order to kind of hit their budgets. So, it's hard to think about expenditures in the global budget model in terms of charges. It's an unusual system, obviously, as I'm sure you all understand. But where we see expenditure, utilization changes, presumably those are contributing to the, those are meaningful changes. But the charges are definitely a big factor as well.
Thank you so much for answering those, Susan. Greatly appreciated. We have a few more questions to address. This one, I'm not quite sure who to propose it to, so I'm just going to open it to all of you, and whoever feels that they can address it best, please jump in. The Q calculations for 2019 by CMS are not accurate. HSCRC, working with CMS, is there a commitment to completing the calculations consistent with Maryland attribution logic?
So I think this is a question also related to the one that we answered earlier from James. We're aware of concerns around the QP calculations for CRP, and we at CMS are working to remedy that situation.
Shane, it's Leslie. I can try to address Camille Bash's question.
Okay, great. I'll go ahead and read the question. That way everyone's aware of what it is. Was there any consideration that non-Maryland hospitals might receive CMS funding outside the claims process while Maryland processes its grant through the claims process, like the transitional partnerships? CMS provides grants to non-Maryland hospitals to support population health initiatives. In Maryland, these are in our charges.
And it's complicated to answer this. The short answer, and Heather and Susan can correct me, the most direct answer is I don't believe we took into account in the control group or explicitly in our analysis grants or other non-claims. I think we did our analyses based on the claims. However, this does, and again, Susan and Heather, correct me if I'm wrong on that. I think we did note, however, that Maryland hospitals also sometimes were able to apply for special grants. It's our understanding that particularly the TPR hospitals had in some cases, reported to us rather sizable support in helping them come up with resources to support this kind of transition. It was also our understanding that the state of Maryland provided special grants and other kinds of programs to support ideas that hospitals in Maryland could compete with. These are probably some unknowables that happen on both sides to our understanding.
Excellent. Thank you so much. And it looks like we have one last question, and we are only have a few minutes left, so that looks like timing is good. Question is, and once again, I'll open it to all presenters, and whoever wants to jump in, go right ahead. Do you have data on EMS diversion hours and/or ED crowding during GBR?
It's Leslie. I can take a little stab at this. We do not have what I would call data. To my knowledge, and again, Susan and Heather, correct me. I will say in our site visits and our discussions with hospitals, we heard a lot about this. There were some perceptions that as a result of GBR, there were more diversions on the parts of some hospital systems and not others. There were some, anecdotally, some concerns among rural hospitals that as a result of GBR, it was more difficult to get into, say, some of the tertiary referral centers in Baltimore City. We couldn't put our finger persistently on any data or evidence that this was something that became more complex as a result of GBR. I think we can say that a big focus of all hospitals under the GBR initiative, was to try to improve ER throughput. That, again, we couldn't tell whether or not this got better or worse under GBR, but we can say that it was a very persistent issue. And as I answered earlier, a lot of hospitals were very, very, very resourceful in figuring out exactly what their ER crowding or emergency department, emergency room crowding issues were, when it occurred, and what resources they could use to try to manage it.
Wonderful. Thank you so much for your answers, everyone. And I do see the time is 9:59, so we are quickly approaching our end, and I do not see any other questions in the chat, but I want to thank all the participants for so many wonderful questions, and I want to thank our presenters today. Now that you can see all their contact information on the screen, Catherine, Heather, Kate, Susan, and Leslie, thank you all so much, and I will hand it back to you for any last comments and a goodbye.
This is Catherine Jerkio again. I just wanted to thank everybody for your time today. As mentioned earlier, we do have the evaluation report available publicly, as well as a 2-page brief overview of the evaluation results that should answer many questions that people have. Thank you all for participating.